Hello, I am Dr. Sarah Pederson. I am an OBGYN and I run a holistic fertility, surgery, and women's health clinic here in Denver, Colorado called Vera Health and Fertility. Today I want to talk to you about how to manage PCOS holistically. So, when we think about PCOS, we think about somebody who has a metabolic syndrome, they have long, irregular cycles, they have hyperandrogenism, or they have PCOS ovaries. So when we think about having PCOS, we want to think about our end goal. So our end goal is that a patient has regular cycles every single month and that they ovulate every single month. So sometimes the default is to put somebody on birth control who has PCOS. However, that is not going to help us meet our end goals because birth control, you're giving the patient artificial estrogen, artificial progesterone. You're not helping any of the underlying causes, and they're going to come off the birth control and be right back to square one where they're having irregular cycles and they're not ovulating. So it is not necessary or good to use birth control to treat PCOS because it does not help. It does not treat any of the underlying causes. Giving somebody a fake period where they're ovulating or where they're having a regular period every single month, but just because you gave them a bunch of artificial estrogen is not helpful to them. So how do we help people with PCOS? Number one, you really want to take a good history as far as how often are they having cycles. Some people who have PCOS are having ovulatory cycles. Some are having anovulatory cycles. You want to know if they have any other comorbidities, obesity, hypertension, insulin resistance, type 1 diabetes. You want to know what they're eating, how many calories they're intaking, how much they're exercising. Sometimes people who are either under eating or over exercising or really stressed or who have a lot of suppression in their HPO axis, so their hypothalamus, pituitary, ovarian axis, they'll have really prolonged cycles and really low estrogen, and those people can get misdiagnosed as PCOS because they have such long and irregular cycles. So get a whole sense of what is going on with the person. How are they sleeping? How stressed are they? What's their nutrition like? That kind of a thing. What are they eating? What do they eat for breakfast? How much protein do they eat? How much sugar do they eat? What do they put in their drinks? Do they have a sweet tooth? Really get into the nitty-gritty of those kind of things so you can make a true healthy plan for them. And then our workup includes blood work and ultrasound. So you want to do two different types of blood work. In a patient who's having regular cycles, you want to get blood work on cycle day 3 and then 7 days after ovulation because you want to know what their LH to FSH ratio is, what their testosterone is, what their DHEA is, and if their DHEA is high, sometimes we'll check a 17-hydroxyprogesterone, and then you want to know what their AMH is or their anti-Müllerian hormone, and you want to know what those things are on cycle day 3. And then 7 days post-ovulation, you want to know what their estrogen, progesterone, LH, and FSH is because you want to see what are the ratios. Are they making enough estrogen and progesterone? Is their LH and FSH equal, or before and after ovulation, do they have significant changes in their LH-FSH ratio? So if you have somebody who is ovulating, you check labs twice. If you have somebody who isn't ovulating or they haven't had a period in a really long time, you just check labs whenever you can. So you get a full cycle day 3 panel. So that's FSH, LH, estrogen, progesterone, testosterone, prolactin, free and total testosterone, of course, DHEA, and then I always get a full thyroid panel and then check vitamin D, iron, and then any other nutrients that you want to check. And then you want to get one labs on one day, and then you want to get labs 3 weeks later because you want to see, is their estrogen increasing, like their body's trying to ovulate, or is their estrogen just on the floor the entire time and they're literally not making enough estrogen ever to trigger an ovulatory event? So in somebody who has very, very irregular cycles, you don't really know what's going on, just get 2 different blood draws about 2 to 3 weeks apart so you can look at the trend. Especially with LH and FSH, it can change radically. Sometimes it can look balanced and then 3 weeks later it can look really, really off. So what are lab values that point us toward having PCOS? If their LH to FSH ratio is 2 to 1 or higher, that's not a good sign because that means that their brain is having to work really, really, really hard in order to try to trigger an ovulatory event. If their anti-Müllerian hormone or their AMH is greater than 3, that's also a sign. The higher that AMH is, the more severe or significant their PCOS. So patients who have an anti-Müllerian hormone or an AMH of 6, 7, 8, I've seen high as 17. Those people, their ovaries are extremely resistant and they're extremely metabolically not functioning well. That's going to be very, very hard to get those people ovulating. So their goal is that we really want to bring their anti-Müllerian hormone down to be around 2 or 3 so that their ovaries are functioning in a healthy way. So we want to know what their LH-FSH ratio is, what their anti-Müllerian hormone is, how much estrogen they're making, because before ovulation you want your estrogen to be between 10 and 80, and then after ovulation you want your estrogen to be between 100 and 200. So if they're really, really low estrogen, then sometimes we need to give them estrogen to trigger ovulation. You also want to know what their progesterone is post-peak. So your progesterone should be 10 or higher 7 days after your peak or your ovulation to make sure that you're having a high quality ovulation to get a good high quality corpus luteum to trigger appropriate progesterone production. And then you want to know what their testosterone is. Everybody who has PCOS has different flavors of PCOS. Some people have high androgen, some people don't. Some people have irregular cycles, some people have perfectly ovulatory cycles. So it really depends on what their underlying hormone profile is, how long they've been having a metabolic imbalance, and there's a genetic component to it, of course. So you really want to dig into the nitty-gritty of almost like what kind of PCOS do they have. So some people have high testosterone, some people have high DHEA, some people don't. So those are goals that you want to have to make sure that if their testosterone is high and their DHEA is high, you don't say, oh, you just have PCOS, it's going to stay high. You want to keep checking it to make sure that your interventions are actually working so that you know that you're actually helping the patient. Just like you want to keep checking their AMH every 3 months to make sure it's actually coming down, to make sure your interventions are working, because PCOS is something that can be 100% managed. Remember, we talked about our goals. Our goals for every single patient with PCOS is to have a regular cycle every single month and ovulate. So PCOS can absolutely be managed, and it can be managed so well that you can have lab values that don't even show that the patient has PCOS anymore. And then you always want to get an ultrasound because you want to get a sense of, number one, is there any other pathology going on that could be contributing to irregular cycles? Do they have ovarian cysts, for example? Do they have endometriomas, so endometriosis on their ovaries? Do they have anything really obvious like fibroids inside their uterus, that kind of a thing? And then you want to know, what do their ovaries look like, right? What are the dimensions of the ovaries? Are they enlarged? Do they have that classic PCOS finding where we see a number of follicles in their ovaries? Because that helps you put the entire picture together. Technically, to diagnose PCOS, we usually use the Rotterdam criteria, which means you have to have 2 out of 3 of hyperandrogens, irregular cycles, or enlarged ovaries on ultrasound. However, sometimes a patient will have what kind of looks like pre-PCOS, where they might not meet all the criteria, but you're worried that they will start developing PCOS if we don't make any changes. So sometimes I'll tell a patient, well, you don't have full-blown PCOS because you don't meet all the criteria, but you do have pre-PCOS. For example, maybe they have a really high LH to FSH ratio and irregular cycles, but their ovaries are not enlarged on ultrasound. Then we still want to work on their hormone balance so that they never develop full-blown PCOS. So we have our patient, we know that they have PCOS, they have a high AMH, they have a high LH to FSH ratio, they might have irregular cycles, enlarged ovaries on an ultrasound. Now, what do we do about that? Number one, the treatment of PCOS always starts with nutrition, because a patient has to be nourishing themselves properly in order to give themselves the building blocks necessary to make estrogen and progesterone in proper amounts, because you need a certain amount of estrogen to trigger follicular development and trigger a high quality ovulation. And then in order to have when you have a high quality ovulation, that will trigger your body to make proper amounts of estrogen and progesterone. So the key is improving their estrogen production. Sometimes people with PCOS actually have really high estrogen, and so then the key is to make sure we're not eating any food that fuels our estrogen production. So if you're low estrogen, we want to get you higher. If you're high estrogen, we want to get you lower. So how do we improve somebody's estrogen levels? So really take a good history about what the person is eating. For example, you really need to be eating about 80 grams of protein a day in order to support healthy hormone function. A lot of people with PCOS who have metabolic dysfunction, they've been eating way too many carbohydrates relative to their protein ratio, and they've been eating way too much sugar and way too much treats. And if you do that for a really, really long period of time, that can really throw you into PCOS and affect literally the metabolic function of your ovaries. So what you want to know is, are they eating a lot of sugar? Are they having treats every day? Are they putting sugar in their coffee? Are they putting honey in their tea? What kind of daily sugars are they getting into their diet? And then you want to set some guidelines for them. So we talked about protein. They really should be getting about 80 grams of protein a day, and you want to be getting 20 grams of protein per meal. You want to make sure that the patient is literally eating breakfast, lunch, and dinner. Intermittent fasting is not helpful. Sometimes people want to do intermittent fasting in order to lose weight if you have a type of PCOS where you have a higher BMI. However, that stresses out your body. When your body's in a time of stress, it, number one, holds on to weight, and it will put all of its energy and resources into making cortisol and not energy and resources into making hormones properly. So you want to talk to them about eating regularly, having breakfast, lunch, and dinner, getting enough protein, lowering their carbohydrate intake, and you really want to go over the details, because a lot of people, when they're diagnosed with PCOS, they say, oh, go low carb and low sugar, but they have no idea what that means. So it's really important that you legitimately spell that out for them. So you want to talk about what are healthy carbohydrates, what are unhealthy carbohydrates, are they doing high quality grains, are they doing things like brown rice and whole grain rice and high quality grain bread and high quality grain pasta. You don't want them to be doing white sugar or white rice or white bread or super refined and processed carbohydrates, because those don't have any nutritional value. You also have to emphasize that they do need some carbohydrates. Like, you do not want to go keto or paleo or carnivore or be completely carb free, because you need the vitamins and whole grains in order to make estrogen. So when we think about promoting our natural hormone production, food diversity is extremely important. You do not want to be restrictive. Even if you're, for example, maybe your patient is gluten-free or dairy-free, then you need to make sure that they're eating high-quality gluten-free grains, because a lot of people go gluten-free and they eat a bunch of rice flour and almond flour. Those are really inflammatory. Those can fuel your estrogen production, and they don't have any nutritional value. So you want to make sure that the patient is getting 3 meals a day, adequate protein. You want to have a 1-to-1 carb to protein ratio. So if they're eating 20 grams of pasta, they need to be eating 20 grams of protein with that. So walk them through what those meals like, talk to them about high quality, good quality carbohydrates, and then give them an 80-20 rule, meaning they have to eat really well about 80% of the time, and then they can have treats 20% of the time. So save the weekends if they want to have a little Starbucks latte or they want to have ice cream on Sunday. Those are times where you can have treats so that it's sustainable, you can live your life. Because another thing about PCOS, sometimes people are just ping-ponging between all these different diets. You want to make sure that what you're talking about is sustainable and they can actually do it. So talk to them about their nutrition, give them some very specific dietary guidelines that you want them to follow, and write them down for them. And then when you follow up with them, you're going to say, okay, were you doing this? How are we doing on protein? Are we eating breakfast? What are we putting in our coffee? What are we doing for treats nowadays? So that we can really hold them accountable, because that will truly help them. So we talk about their nutrition. Then we want to talk about their exercise. Everyone with PCOS should be moving their body, but it just depends on what your hormone profile is like. If you're a person who has a high testosterone and you run high estrogen, you're a person who's going to need to do a lot of exercise in order to burn off and metabolize and process your hormones. So those are people who can get away with doing HIIT and spin and working out a lot. If you have a low estrogen profile, you've checked their estrogen multiple times, it's low, then those people have to be more nourishing to their bodies and more gentle. So they have to do more yoga, bar, Pilates. They still have to be moving their body, but they don't want to be doing HIIT and spin where they're burning off all their hormones. They're feeling completely exhausted at the end. So talk to a person about their exercise and write it down and give them something very specific to do. The other thing that you really want to talk about is stress, because when you are stressed and your body's making a ton of cortisol, it's not going to be making hormones properly, because it's diverting all of your nutrients into making cortisol instead of making estrogen, progesterone, and testosterone like it's supposed to be. So you want to talk about what is their stress. Do we need to literally check their cortisol levels, just to give you a data point, and then literally healthy ways to manage their stress so that they're not suppressing their hormone production. So, and then you want to talk about their sleep, of course. Sleep is the cornerstone of health. Every patient needs to be getting 7 to 9 hours of sleep, because if they're not sleeping well, they're not going to be able to control their blood sugar for the whole day, and they're going to be really stressed. So that leads to a lot of metabolic and cortisol dysregulation if you're not sleeping well. So you got to talk to them about nutrition, exercise, stress, sleep. Usually when somebody has PCOS, I really don't talk to them about losing weight, because that's really, really frustrating. I really focus on nutrition instead and getting healthy. And then with that, the weight loss will come. So we talk about our hormone health goals. We talk about our nutrition goals. I really don't tell them, oh, just lose weight, because that's not helpful at all. It's very stressful. It's much more helpful to think about lifestyle things as far as like their nutrition, their sleep, and their stress, and then the weight part will come later. So if you have a person who you're worried about their insulin resistance, I would definitely have them do continuous glucose monitoring, because data when you're trying to manage PCOS is very, very helpful. So order them a CGM or a continuous glucose monitor and have them wear it for 10 to 15 days, depending on what the company is, because you want to know, is their blood sugar low? Is their blood sugar high? What is their insulin resistance like? It can be helpful to check a hemoglobin A1C and a fasting insulin level. However, that does not give you the full picture. I see lots of people who have a normal hemoglobin A1C of 5.2, 5.3, but when they eat, we do a CGM and their blood sugar gets really high when they eat. So you want to get a full picture of what's happening. So have them do a CGM, have them keep a really good food diary, because people who are spiking their blood sugar or who have a high fasting have a high fasting blood sugar all the time, or they're consistently spiking above 140 every single day, that will make their PCOS worse. So in order to manage the nutritional part of PCOS, you need to be having a fasting blood sugar of less than 95. You need to have an average blood sugar of less than 100, and you never want to spike above 140 unless you're having a known treat once or twice a week. So those are guidelines that you can give patients when you do their CGM, and you have them do it for 2 weeks. You go over it with them. You set specific guidelines. If we didn't hit the goals, you have them do it again, because having that data can be really helpful. It holds them accountable. It helps them learn certain carbs that they can and can't have. For example, sometimes people can eat Dave's Killer Bread and they don't spike. Some people, they eat Dave's Killer Bread and they spike their blood sugar really, really high. So it helps you personalize what exactly carbs can you eat that don't spike your blood sugar. Are you eating enough protein and enough vegetables to keep your blood sugar flat all day long? Because PCOS is a chronic illness. It's something you have to manage forever. You do not want to be ping-ponging back and forth between different diets. You don't want to be carb-free. You don't want to be sugar-free. That's totally miserable and not sustainable at all. So you want them to learn, okay, if I have a treat, maybe I can eat ice cream, because ice cream doesn't spike my blood sugar, but candy really spikes my blood sugar. So you can help empower them to make great decisions for their long-term hormone health. So I highly recommend doing blood work and CGM to get a sense of their glucose profile. And then when we think of medications, then you'll be able to know if you want to start something like either a supplement to help them regulate their blood sugar, like myo-inositol or berberine, or if we need something major like our metformin, our Jardiance, our GLP-1s. Those kind of things can be really helpful depending on their glucose. So if you have a patient who has irregular cycles and they have a low blood sugar all the time, that's not somebody that you want to put on metformin, because metformin is going to make their blood sugar way lower. So metformin is good if you have true insulin resistance and you have a high fasting and a high average blood sugar. So before you just throw somebody who has PCOS on metformin, make sure you know what their glucose profile is, because otherwise it's not going to help them. It's going to make them feel terrible. Another thing that you really want to focus on is their gut health, because sometimes people with PCOS, they've just been eating a lot of carbohydrates, or a lot of unhealthy carbohydrates, or a lot of sugars for a long period of time, or they're just literally not nourishing themselves. They've been restrictive for a long time. There's certain things that they don't eat. They're a really picky eater. There's things that they don't like. They're eating a lot of white or refined carbohydrates. That over time will really throw off their gut health. So you want to emphasize things like high quality grains and different sources of fiber, so your insoluble and your soluble fiber, because estrogen is metabolized and recycled in the gut, and so we need to be pooping every single day. We don't want to have any bloating or gas, because gut health is extremely related to hormone regulation and PCOS. So get a good gut history. How often are they pooping? Do they have to think about having a bowel movement? Are they constipated? Are they running diarrhea? Are they bloated or gassy? Because then you want to look at their diet and make some tweaks. In a perfect world, it is helpful to have them do a gut health test or a stool test, so we can see whether they're digesting food well, absorbing food well, look at their gut microbiome, make sure they don't have anything like parasites or E. coli or bacterial overgrowth that need to be treated. And sometimes it's helpful to check for things like SIBO and H. pylori, depending on what they tell you, if they have bloating or gas for SIBO, or if they have a lot of GERD or reflux, or they're not digesting their food properly, then you might want to think about testing for H. pylori. It just goes to show that PCOS literally involves your entire body, so you need to get a full picture of the patient in order to help them properly, because the cornerstone is truly, truly nutrition. So we talk about their gut, we look at their nutrition, their exercise, and then we can talk about supplements. So we talked about blood sugar, so starting your myo-inositol or your berberine before you start any medication to see if that helps with their blood sugar. And then you have them repeat their CGM and see if their blood sugar is coming down. And if it's not, then you can add in metformin or Jardiance or something else to help them with their blood sugar. And then when we think about other supplements to help them regulate their hormones, you want to obviously know what their hormone profile is. So if they're a person who has really high estrogen, you can use something like DIM to help them metabolize their estrogen. If they're really low estrogen, then you want to do things like Vitex or chasteberry, omega-3, magnesium, or B vitamins, depending on their nutritional status, to really help them boost those estrogen levels. So you don't just want to recommend random supplements. You want to recommend supplements that are tailored to that specific person's metabolism, glucose, and hormone profile. So that's extremely important. And then when we think about getting them to have regular cycles, if they don't already have regular cycles, you really want to retrain or jumpstart their body into having regular cycles. So if they're low estrogen, you might consider them putting them on estradiol every single day so that we can get enough estrogen to trigger an ovulatory event. If they're low progesterone, you might want to consider putting them on post-peak progesterone, but make sure you always pay attention to their estrogen-progesterone ratios. If you have somebody who's low estrogen and low progesterone, you need to put them on estrogen and progesterone, not just progesterone, not just estrogen, because we really want their ratios to stay proper, meaning you want your progesterone to estrogen ratio to be 1 to 10. You don't want to throw that off, because that is what stimulates a healthy uterus lining. So sometimes you'll have to give them either cyclic estrogen and progesterone or cyclic progesterone in order to get them having regular cycles. Please pay attention to their estrogen status. If you're somebody who has low estrogen and they have a really thin uterus lining and you give them progesterone, they're not going to have a withdrawal bleed, because they don't have enough estrogen on board to thicken their uterus lining to even have a period. So if you have a patient who has really irregular cycles, make sure you get an ultrasound and blood work so that you can see what their uterus lining is, see what their estrogen level is, because if their lining is really thin and you give them at bioidentical progesterone, they're not going to have a withdrawal bleed because there's nothing to bleed. So then what you need to do is you need to grow their lining with estradiol, bioidentical estrogen, and then you can give them progesterone and have a withdrawal bleed. So pay attention to that, because it's not universally helpful to just give somebody progesterone to have a withdrawal bleed. You need to know what their lining is and what their hormone profile looks like. So but if they're a person who has really high estrogen and they have a thick lining, it will be helpful to just do progesterone. So you give them progesterone for 10 days and then they stop it and then they have a bleed. And then usually you'll want to repeat that for 3 cycles in a row, because the first thing you want to do is get them to have regular periods. And so usually I have them monitor their ovulation. So our goal is to be ovulating before cycle day 21. And if they are ovulating, they start their progesterone and or their estrogen 3 days after they ovulate. If they're not ovulating at all, they don't have an LH surge by cycle day 21, we say go ahead, start your progesterone by cycle day 21. So first step is to get regular cycles. Second step is to ovulate. So it can be helpful to use ovulation medication in our PCOS patients. Most of the time we'll start with letrozole, because that can help jumpstart ovulation. Sometimes just eating in a nutritious way, getting our exercise up, getting our stress down, that alone can restore our hormone balance. And then if that doesn't help, then we can start ovulation medication. Usually you have to do ovulation medication 3 months in a row to retrain train their bodies how to make hormones in proper amounts and help jumpstart ovulation. But make sure you're getting data every single cycle and watching them really closely. For example, if we start them on letrozole, we want to make sure they're truly ovulating by cycle day 21. If they're not, then we need to increase the letrozole dose for the very next cycle, or add metformin, or make some kind of tweaks to make sure that we're meeting our goals every single cycle. So you also want to be checking blood work to see that if they're having low estrogen and progesterone, is the intervention that you're doing, number one, making them ovulate, and number two, improving their estrogen and progesterone profile, right? If you are decreasing their cortisol levels and you're getting them to be ovulating, then their testosterone and their DHEA should be coming down. So you want to keep repeating that often, at least every 4 to 6 weeks, so that you can make sure that what you're doing is working and is coming down. So what you want to do is get them ovulating for 3 months in a row, and then if they're on medication, you come off of the medication, and then you want to make sure that they can ovulate on their own. So in the beginning, just managing PCOS, it can be really time intensive, but what you need to tell the patient is that my goal for you is you're going to put in all the work, you're going to do the homework, you're going to learn about your body, you're going to learn about your hormone profile, you're going to learn about your metabolism, and then you're literally going to be empowered with the tools that you need in order to manage your PCOS forever and ever and ever, put it into remission. And your goal is that you never need me anymore. I had a patient who came to me. She was 21 years old. She had extremely irregular cycles, and she had a really, really low hormone profile, and she had really bad insulin resistance. And I had her do continuous glucose monitoring, and she said, Sarah, I'm shocked at what I had no idea that I was eating so badly. I have a sweet tooth. I was having Starbucks lattes. I thought I was eating really healthy, but I actually wasn't. So she really cleaned up her diet. She started eating a lot of protein. She cut out sugar. And then we gave her some bioidentical estrogen, and we cycled her with estrogen and progesterone to get her cycles regular. And then we gave her letrozole for 3 months in a row while she worked on her diet and worked on her exercise profile. And I had her repeat her glucose monitor, and her average blood sugar was 90. So she got it down a lot. Her AMH went from 8 to 4. So we know that she was truly improving her PCOS. She came off her letrozole. She was ovulating perfectly fine on her own. And she had 3 months of beautiful ovulation with no medications, just managing everything with diet alone. And she said, Dr. P, it's been great, but I literally don't need you. I'm doing great. And that is exactly my goal for her and all of my patients, that they understand themselves, they know what to do, and they say, I'm great, I don't even have PCOS anymore, I know how to manage my hormones. If something starts going awry, I know how to bring them back on track. So please, when you're managing somebody with PCOS, it's going to be work intensive in the beginning, but it's totally worth it, because your goal is to empower them to feel amazing every single day, to have a regular ovulatory cycle, to understand their body and know how to manage their own body. If you have any questions at all, please don't hesitate to reach out to me. My email is Sarah with an H, Pederson with a D, so Sarah Pederson at verafertility.com. Please check us out at verafertility.com, and good luck with your career and your journey.